So I'm Lynn Kinst. I'm the Executive Director of the Hemophilia Council of California. I want to welcome you to our Advocacy and Public Policy webinar today, Navigating Your Care and Treatment, a Medicare Example. So with that, I would like to introduce Marla Feinstein. Marla is a graduate of Boston University. She also did graduate work in physiology and molecular biophysics. And Marla, as long as I've known you, reading this today, actually earlier, I learned all of this about you that I didn't know. She was awarded a National Institute of Health Predoctoral Training Fellowship, has an MPH or a Master's in Public Health and Health Policy from Columbia University, and formerly was a consultant for the New York State Governor's Office and Department of Health. She's currently the Senior Policy and Healthcare Analyst for the National Hemophilia Foundation and has been instrumental in advocating for bleeding disorders at the national and state level. And really, I have to say that when Medicare issues come up, and I get contacted by a community member who is having a difficulty navigating Medicare or has a problem, she is the first person I reach out to. And so I'm thrilled to have her on today to be able to share that expertise with all of you. And we also have on today Randy Curtis. I think a lot of you folks in California especially know Randy and what an advocate he is for the bleeding disorders community. He's a past president of the Hemophilia Council of California and has done a lot of work in terms of hemophilia research and quality of life measures. And we appreciate him joining us today. So towards the end of the webinar, he will share a little bit of his experience and may pop in to ask a question or make a comment here and there through the presentation. So with that, I will remind everyone that, as questions come up, please feel free to type them in the chat and we will get to them at the end. And we look forward to hopefully what I know will be a very informative presentation for all of you. So Marla, I am going to turn it over to you.
Excellent. And thank you guys for inviting me. Thanks to the council for, actually promoting Medicare, which is a refreshing change. Next slide, please. Just in case anyone hasn't seen this, this is NHF's updated mission statement. Next slide, please. And I'm just going to get to the heart of the matter, which is Medicare. We're all here to listen about Medicare. And as you've probably seen on television, Medicare is also a hot topic, whether it's open enrollment, whether it's drug pricing. Medicare is always a hot topic. Well, in my very, very small world, it's a hot topic. Okay, what is Medicare? Medicare is broadly a federal program, right? It provides health insurance for those 65 and older or those under 65 with certain disabilities. For example, if you have Lou Gehrig's disease or ALS, you can qualify for Medicare without a waiting period, and any end-stage renal disease. Whoever the policy people were that advocated for end-stage renal disease, 2 thumbs up because they're excluded from everything. But what the heart of the issue is that Social Security actually enrolls people in Medicare. Most people don't know that. So when people ask questions about enrollment and disability qualifications, those are all very separate from the Medicare program actually. Right? Those are the enrollment people, and that's done through Social Security Administration. CMS, the Center for Medicare and Medicaid Services, is actually the program or the agency that deals with coverage, benefits, payments, and all of that kind of jazz with Medicare. What is important about Medicare is that you have to be a U.S. citizen or lawfully present in the U.S. and must reside at a minimum of 5 continuous years. If you don't meet those qualifications, you will not be eligible for Medicare. Next slide, please. Medicare comes in 4 varieties, and I always find this fascinating because, it's the alphabet, right? And you would think it would be continuous, but let's just break down those parts of the alphabet. Part A is what is known as hospital insurance, right? It's inpatient services. So, right, it's inpatient hospital fees, inpatient factor coverage. But it's also important to remember that the patient is responsible for an inpatient deductible. Okay, so in 2021, for each benefit period, that was, roughly $1,500. Medicare Part B is more your outpatient or your medical insurance, right? And this covers clinical visits, doctors, labs, what have you. This is where factor is covered, right? For home use or or at an infusion center. It is covered under Part B. And we'll revisit that throughout, because it becomes important when you think about the holistic approach to Medicare. In addition, Part B has monthly premiums, okay, which were $148.50 in 2021. It also has copays and it has a deductible. The annual deductible is lower. It's around $203. But it's important to remember that every time I talk about costs, just sort of keep it in the back of your mind, because these costs add up over time, okay? And then you have Part C, which is a Medicare Advantage plan. This is an entirely optional, it's not a required purchase, and we'll go through the differences between these things in a bit. But it is a private plan. What this private plan does, it bundles A, B, and usually Part D, as in dog. And these are private plans that Medicare oversees. So it is private health insurance administering part of Medicare. And these are typically HMOs or PPOs. And the costs vary widely in terms of Advantage. Drug coverage. And that's a pretty easy thing to remember, right? These are private plans that, again, contract with Medicare, and they can be standalone or they can be included in an Advantage plan. And these cover the typical drug costs outside of factor after the deductible is met. And these also contain a number of copay cost share requirements, and these costs also vary by plan type. Why do I mention that? Because everyone says, well, I don't need Part D. I'm like, no, you do, but factor is covered under Part B, as in boy. And I'm like, right, but every other medication that you likely take or will likely take, if you're taking heart medication, cholesterol medication, HIV drugs, hepatitis C drugs, those are all covered under Part D. Pain meds are covered under Part D. So when my hair stands up is when someone says, well, I didn't get a Part D plan because I only cared about factor. I'm like, well, you're going to be out of luck when you're trying to get your pain meds, which is when you usually find out that the person doesn't have Part D, as in dog. Next slide, please. Medicare basically comes in two varieties, something called original or traditional Medicare, which is what you see here on the left-hand side of your screen, and Medicare Advantage, or Part C, okay? All this is the take home. You can't be in two places at once. Either you have original or traditional Medicare, or you have an Advantage plan. You cannot simultaneously have an Advantage plan and traditional Medicare, okay? And included in that original Medicare is only Part A and Part B. To that, you can add Part D for prescription drug coverage. Also to that, you can add a supplemental or a Medigap plan. And this includes, it's a way of paying, because you've all heard of the 80-20, right? Medicare pays 80%, you're responsible for 20%. And then people flip out because they think they have to pay the 20% of their factor costs. But if you have supplemental coverage, you don't have to pay that 20%, right? It acts as a secondary insurer. So you can have all these sort of different parts of Medicare, and knowing fully that you can only be in one place at a time, okay? But it's important to remember that all of these things, your individual choices with respect to how you want to deal with out-of-pocket costs, or how you want to deal with if you travel a lot, if you go out of the country, these are all different terms and conditions that you, the individual, must consider when you're either enrolling in the left-hand side or the right-hand side, traditional or an Advantage plan, okay? And why? It's important to remember that for the original Medicare, right, you're going to need help. You're going to need help paying those out-of-pocket costs, which is why I'm like, Well, why didn't you get a Medigap plan, or why didn't you enroll in an Advantage plan so you wouldn't be responsible for those 20% costs? Unlike in Part C, where it just kind of bundles everything and you make a single payment, basically, to the insurer. Next slide, please. Sorry. Okay. So why am I making a big deal about this? Because everyone knows there are benefit gaps, right? You need some sort of protection against these gaps, so you're not stuck with that 20% cost that traditional Medicare has. Because everyone also knows that Medicare has a high deductibles and a lot of cost sharing, and there are no cap limits, or out-of-pocket costs are not capped for Part A and B in Medicare. In that they don't also pay for services, including long-term care support services, vision, dental, and hearing still maybe, but we're not sure. We'll have to see how Build Back Better comes along. Again, Part D coverage varies, right? You still have the donut hole. It may in fact be capped, TBD, on the Build Back Better thing. But again, these expenses are not capped currently, and you still have to pay 25% of the cost of drugs that are within that gap. Yet, 1 in 5 traditional Medicare beneficiaries have no supplemental coverage, meaning they're not enrolled in an Advantage plan, and they don't have any Medigap plan. That is a lot of people. Do not be one of those people, okay? And I mean, whether or not you have a private or previous employer-based coverage, whether you have a Medigap plan, whether you have Medicaid or some sort of other union veterans benefits, what have you, you just don't want to be in the red here in this no supplemental coverage, where you are in fact responsible for paying the remaining 20% of those costs. So when you join traditional Medicare, right, you can pick a supplemental plan or a Medigap plan to help cover these deductibles and co-pays and co-insurance. Next slide, please. Now let's go a little bit deeper into what a Medigap plan is and what it isn't, okay? Medigap plan in order to purchase a Medigap plan, you have to have Part A and B. And again, you cannot have an Advantage plan because you can't be in 2 places at once. Why is this important? Because if you want a Medigap plan, Medicare has only a guaranteed issue, unlike the ACA, which means that you can't charge based on health status, they can't reject you, and those kind of things. That there is no guaranteed access in a Medigap plan after that 6 months, okay? So once you enroll in Part B, that's when it starts the clock. So you only have guaranteed access, meaning that they have to give you a Medigap plan, and they can't charge you more during that 6-month period, okay? On that 7th month, they don't have to take you. There's no guarantee. Medigap plans act to only supplement the original Medicare benefits. That's why it's called the supplemental policy. Again, these are sold by private companies, right? In that it fills the gaps that traditional or original Medicare doesn't pay for. In general, you have to pay the premium on a Medigap policy, as well as any Part B premiums you still have to pay. So those are 2 separate payments. Each Medigap plan is standardized, and we'll go through that in the next slide, meaning that they must offer, if it's a Type A plan, they're all Type A plans, whether it's offered through Aetna, United, Blue Cross, Blue Shield, must cover the same basic benefit structure. However, based largely on regional variability, right? So that if you're in Northern California, if you're in the Bay Area versus LA, your premiums and costs are going to differ. Policies in general sold, now 15 years ago, sold after 1606 do not have our prescription drug coverage. For prescription drug coverage, again, you need Part D. And again, these by and large do not include any sort of additional bells and whistles, whether it's silver sneakers, vision, or dental. And again, I cannot stress this enough. It may be difficult to enroll in a Medigap plan if you originally choose an Advantage plan. And that is because you're likely outside of this 6-month window by which you enroll in after Part B. Next slide, please. Okay, and when I was talking about Medigap plans, I was saying that they're standardized, okay? What does that mean? They have letters. That's basically all that it means, right? So that all plan A's and offer the same benefits, B's and so forth, okay? And I'm not going to go into detail about what they do and do not cover because I do not have that time. What I want to say is that if one thing versus another thing is more important to you, then pay attention to which that covers, right? If you don't care about whether or not it covers travel, then don't worry about whether or not your plan includes travel, okay? Or coverage for travel, right? What I do want to point out is that there are plans that cover 100% of the Part B excess charges, which may be of use to some people in this community, okay? And there are plans that cover 100% of the deductible, okay? And there are a couple of plans that now cap their out-of-pocket costs, but these are limited, okay? And those cap on out-of-pocket costs are still quite high, in my opinion. So, if you have an out-of-pocket limit of $6,000 or $3,000, I mean, that's kind of really ridiculously high. So you might want to reconsider whether or not that is a valuable, valuable option for you. I just posted a link to all the supplemental plan coverage. Next slide, please. Okay, now let's get back to a Medicare Advantage plan, which it turns out it may be a better option than, sort of taking the puzzle and putting it together with a Medigap plan, right? Let's talk about costs. Costs vary widely, right? Because a Medicare Advantage plan is, again, a private plan, right? That's going to bundle all these costs together. And I know bundling is a bad word sometimes, but now that we fixed the SNF issue, bundling is a very good word. Okay, in that you have to pay, the monthly Part B premium, and you may also have to pay the plan's premiums. Plans may have a $0 premium, and they may help pay for part of your Part B premium. And most of the plans that are Medicare Advantage plans do in fact cover Part D. Above all, they have an annual limit on out-of-pocket costs, right? And once you reach your plan's limit, similar to, private, employer-sponsored health insurance, you'll have to pay nothing for those Part A and B services. But what is, again, important to remember is if you're enrolled in a Medicare Advantage, you cannot buy, and you don't need a Medigap plan because, again, you can't be in two places at once. Plans must cover medically necessary services that all Part A and B covers, okay? But the Advantage plans also differ on the number and types of these extra benefits or special services, vision, dental, hearing, the only one that was included in the Build Back Better was hearing tentatively. So let's wait and see how that all washes out in the end. Part D is included in most plans, and that so you don't have to join a separate Medicare drug plan. But much like every other health insurance policy, some services may require prior approval before you can, get an MRI, for example. Because of these are private plans, and usually HMO or PPO or POS, in that you need to use in-network providers, much like you would for your current employer-sponsored health insurance. Some plans do, in fact, offer non-emergency out-of-network plans cover, but like when you think about network services, if it's outside of the network or if you have a larger network, you're going to have to pay more. And in fact, you may need a referral to see a specialist. Next slide, please. So here is something that Medicare doesn't like, but I like to think of things like a side-by-side, right? But you can't necessarily compare an Advantage plan and a Medigap plan. What you can do is sort of think a little bit about What are some things that, you know, people would have concerns about? Okay. Medigap insurers can reject you or charge a higher premium, again, if you're outside of that 6-month window. Okay. Whereas Advantage plans must accept everybody and everyone charges, no one's charged more because of health status. Traditional Medicare, you know, without a Medigap plan, except for those 2 limited exceptions, has no cap on out-of-pocket expenses, which is still crazy to me. Okay, and those can be really high in the tens and thousands of dollars. Advantage plans can cap out-of-pocket. I mean, it's still $75.50, excluding Part D, but that's better than an unlimited cap, right? And some Medigap plans, when purchased with, you know, traditional Medicare plans, cover the vast majority of these 20% of expenses. And why do I say that? Because guaranteed issue is a thing, right? We know it's a thing because we all went through the ACA 850 times that we have talked about it, but that it's been brought up and challenged, right? Guaranteed issue means that you're you can continually enroll or maintain insurance. And why is that important? Because currently only 4 states have a guaranteed issue when with respect to Medigap plans. So most people find it surprising when they try to enroll in a Medigap plan and only to learn that, when did you purchase Part B? I don't know, 2 years ago. Okay, well now we can rate based on health status and we can reject you if you're not in those 4 states. And that's highlighted in this little map on the side. And I just sort of did that to remind myself to talk about this guaranteed issue. And I pulled a little facts about, you know, so I was like, well, maybe California is different. Maybe California does have some standards that otherwise some of the other states don't have. On Kaiser Family Foundation's website, you can also go through and sort of see what are the requirements based on states, right? This is from 2017, but unchanged, right? So it doesn't have a guaranteed issue, either continuous or annual, okay? In that the qualifying events, okay, upon retiree benefit changes, sure, you can enroll. Upon loss of Medicaid eligibility, sure, you can enroll. And then you have qualifying life events, which are similar to other qualifying events, in that the beneficiary, if your plan changes, your participating hospital that you need leaves, or it's excluded out of network, which in fact does happen. In those situations, you can in fact switch to a Medigap plan or a Medicare Advantage plan. Next slide, please. And I know I'm running out of time. I'm talking really fast, so I'm sorry. Okay, but all I wanted to say is that every year you have the opportunity to enroll and re-enroll and can pick your plans and you know, cover your options, right? Right now, you know, we're still in the annual open enrollment period. Medicare enrollment, initial enrollment, special enrollment, and open enrollment are all distinctly different. And it's kind of confusing, and I didn't want to put that slide up. But I wanted to say is, this is your time. You have 7 weeks in which you can either switch to an Advantage plan, switch to traditional Medicare with a Medigap plan, right? And you could do this every year, okay? With the caveat that you may not be, you know, if you leave a Medicare Advantage plan, you may not in fact be able in your state to get a Medigap plan, okay? This gives you a full 7 weeks before you can receive, have your cards in hand for January 1 coverage. Next slide, please.
Yeah, hey Marla, real quick, I know Randy's gonna have to hop off in just a minute, so I'm gonna just pause briefly and let him share a couple comments, and then we'll pick back up and answer questions, okay?
Okay.
Hi, so I kept my state job for 35 years, so I had good health insurance. And when I got close to 65, they told me in no uncertain terms that I needed to sign up for Medicare on the day of my birthday or 2 weeks later, or else bad things would happen to me. So I was scared, but they had a supplemental plan so that my Blue Cross coverage slid into this supplemental plan flawlessly. And I had, once again, this is only my experience, there was no break in coverage. And actually Medicare and the supplemental plan was actually better than my original plan. So that's my perspective of how Medicare worked for me. But I've been surprised at how well it works for reimbursement for my condition. So I hope that's the patient perspective in 10 seconds or less.
And what I will add to that is Randy is in fact right? If you have, and that's in a later slide, if you have an employer coverage or retiree coverage or your spouse's, you can use that as your supplemental plan. And those plans, if you work for the state or the federal, or any sort of state or federal government or a union job, have fantastic coverage, fantastic. And it's coupled with Medicare, provided it's, creditable coverage, and Medicare will verify that for you. So yes, Randy is 100% correct. And it probably is better.
All right.
Thanks, Randy.
Gotta go. Bye.
Marla, you can go ahead and pick up here.
Okay.
And for everyone else's benefit, we're going to finish through the last few slides here, and then we do have some questions in the chat that we will stay on to answer for those that want to hear those answers. And so let's keep going.
Okay, so you could just skip the next slide. Because let me just one statement, don't skip it. These are just some questions that you should consider when you're reviewing your plan, like what are some of the things that you want to worry about, right? And just when you should reevaluate your options. Next, please. Okay, this is important. So coordination of benefits. Medicare is weird in that they have very long and detailed protocols and laws in order to coordinate benefits. It is super important that you tell everybody, right? Whether it's your providers, whether it's your insurers, if your employer, right? Just as Randy mentioned, if you have employer-sponsored health insurance, tell your employer or the benefits administrator, because if you have concerns whether or not your coverage would count as supplemental, ask your employer or ask your benefits administrator, right? And quite often, if you have very strong union-based coverage, it will in fact act as a perfect supplemental plan in that you can enroll, in that you can maintain that coverage and enroll in Medicare. But what is super important is that if you have any changes or other insurance, you have to let Medicare know. Medicare is not magically going to say, oh, Lynn, I see that you've changed your job and your coverage, right? You have to let them know. And you'll have to let all the providers and insurers and so forth know that in fact you have multiple forms of coverage, right? And don't worry about who pays first. Trust me, Medicare will tell you when they know, okay? And quite often it's Medicare determines who pays first. The coordination of benefits, if you just go to medicare.gov and search coordination of benefits, there are multiple manuals about exactly how, in fact, they do coordinate benefits. Next slide, please. Okay, and this is just a standard, okay? Don't decline Part D, please. Just because you are not on any medications now, as I made the pitch earlier, if you are on pain meds or any other meds, heart, cholesterol, or will be on those meds, you will need to have Part D. Moreover, you'll be penalized for each month you decline Part D or Part B for the rest of your life. Okay, so if you're sitting there going, I don't need it, right? Well, and then it turns out you do, right? You have to sort of pay if you don't have other creditable coverage. And you can order to find out whether or not you have creditable coverage, right? You can ask your employer and whatever. This is all about finding this balance between affordability and access, right? Medigap plans or supplemental plans have higher premiums than Advantage plans, and more expensive ones offer greater out-of-pocket protection costs, coverage. That is important to some people. And it's just a matter of deciding if that is important to you. Do you want to have higher premiums and more coverage, or what do you want, more programs in Advantage? Next slide, please. Okay, this is pretty self-explanatory. There are limited financial assistance options, okay? These limited financial assistance options, we'll go through on the next slide real quick, and are based, next slide, are based largely on income and resources. Here, Medicare knows people are on a fixed income, okay? Medicare does appreciate that. Okay, there are a number of different ways that you can qualify and what you can qualify for based on these series of federal programs. There are federally funded programs that can pay part or all of your premiums and or deductibles based on what your income is, your assets are. And if you qualify for any of these, the Quimby, the Slimby, or whatever, right, that you have to remember that these will also likely qualify for you for the Part D extra help coverage, okay? Some other forms of assistance are, okay, Medi-Cal, right? Medi-Cal is your state Medicaid program. There's also state pharmacy assistance plans, and 21 states currently have assistance plans. There are PACE programs, or all-inclusive cares for the elderly, which basically bundle Medicare, Medicaid, or dual eligible. Next slide, please. Changes happen. We know this, okay? Plans can change, as can their costs and coverage options. Some plans may choose to leave Medicare entirely, okay? But plans are required by law to mail or provide electronically an annual notice of change, which explains these changes and the departure from last year's coverage, and the explanation of coverage, right? Why is the coverage changing, and how can you go about figuring that out? And review the plan before open enrollment, as always, right? Because you want to know, they'll often publish the options. They're never like, oh, you need to enroll by midnight tonight, right? They're going to give you a window. In Medicare's case, it's 7 weeks. So review during that time and make a wise decision. Next slide, please. As for help, these are help resources. Next slide. Okay, and then there's Lynn has Lynn can send you a PDF of all the slides, which has a number of resources, right? There are non-biased sources non-biased people who are resources, and they know a lot about Medicare. They may not know a lot about hemophilia, but they sure do know a lot about Medicare. They have access to forms and templates that we can't possibly know. So if you went in there explaining that factor is covered, or any sort of bleeding disorder treatment is covered under Part B, they can fill in the rest. So don't discount the SHIP, State Health Insurance Assistance Program people, which are your local health people, when you're shopping for plans. Next slide, please. And SNFs implementation law. I just shout out to SNFs. SNFs are currently covered. Medicare covers SNFs under. We were able to pass the law. So if you or any of your loved ones, and I'm sad that Randy left because his idea for nursing homes in California is kind of gone. They are, we'll figure out a way, because the SNFs are learning about us, we're learning about them, and it's there's a lot of education to be had. So if you need assistance, please reach out to us and just me, and we'll figure it out. Okay. And I think that's it. And now I can answer questions, and I talk super fast. I'm sorry.
Marla, thank you so much. This was super informative and helpful. I want to also thank Oh, go ahead.
Sorry, before you thank that sponsor. So you'll send out the open enrollment in California 2022 fact sheet, as well as the slide deck, correct?
Correct.
Because there's a lot of really great It has a link to the handbook. It has all these important dates and deadlines and when things start. It gives you a lot of specifics to California about the Medicare Savings Program and the number of plans offered in your state and what percentage, blah, blah, blah. So
Yeah, we'll send that out to everyone who registers.